I think we we give people a couple of minutes to get themselves organised. If anybody wants to say hello in the chat, yeah, I can see some people are, really nice to hear from you. Everybody's really welcome here this morning.
And Christina, I'm really looking forward to today. There's such a breadth of topics being covered. I think Rihanna's clearly worked extremely hard with the team to pull together a program that's going to be really stimulating. So welcome everybody, and really thanks to Rihanna for working exceptionally hard, I think, to pull something together for us to look at the breadth of what's going on across our region. Really nice morning ahead.
Yeah, I couldn't agree more, Andrew. And we have our first hand of the day. Kirsty, did you have your hand up? Oh, oh, was that meant to be a clap?
It was an error hand, I apologise. I was just wanting to clap in terms of Rihanna's organisation. Yes.
Fabulous. Yeah, brilliant. Thank you. So as the day progresses, we're just going to start with a couple of the general housekeeping that we all start with. So please ensure all cameras and microphones are off for the duration of the forum. I think the reason is that sometimes when we've got lots of faces on screen, it can affect the internet or whatever the technical term is. So any comments or questions in the chat, and these will be responded to at the end of all the sessions. So please, don't hesitate if you've got a comment, if you've got a question. We've got the trusty Rihanna on hand to kind of remind myself and Andrew what the questions are, and we'll make sure that they're attended to at the end of the session. So all slides will be available and circulated across the network after the event. So if you don't, if you don't find those landing in your inbox, do give us a shout, give Rihanna a shout, and we'll make sure that you get them for you. The session today is recorded, just to make people aware of that. And the other thing to mention is that a couple of the sessions today are pre-recorded, and we also have, here we are. We also have an apology from Irini, who's not able to join us this morning. Unfortunately, she's not well. So we have Dale Huey has very kindly stepped into the breach, and he's going to present her part for her. Anything I've missed there, Andrew, in terms of housekeeping?
No, other than our first break's at 11 o'clock. So we'll get a 15-minute break then for people to have a stretch and make themselves a cuppa. And then we'll finish at 1.
So Rihanna's kindly put the agenda up for us this morning, and as Andrew has started with this morning, what an interesting day we've got. We have our expert by experience slot, which has become one of our standard slots in this forum, and really valuable to have that perspective. It's really key to our understanding of what it's like to receive our services and services in general. Then followed by our research slot, and we've got 3 really interesting presentations today. Our comfort break, followed by a clinical focus slot. We have our employment advisors, which is topical, I think, for all of us at this point, as we're trying to welcome employment advisors into our services. Then we have the national and regional updates, which again, it's always really, really useful to be linked in and keyed into, kind of what's happening in that kind of larger Talking Therapies family. Any questions or comments so far? Any thoughts? Okay. So we've had a thumb. Fabulous. So the first item this morning is our, I think it's a pre-recorded session from our experts by experiences. So how can NHS Talking Therapies benefit from our involvement? So it's an animation and discussion toolkit that has been produced by the Northwest PPN Expert by Experience Steering Group. And I think we have Leanne, who is also involved with this session this morning. So I shall hand over to you, Leanne, to take us
Great.
through that.
Thank you, Christina. So yes, it's a partially pre-recorded session because some of the speakers couldn't be here today. So I shall share the screen and I'll talk through some of the slides as well. Make sure I share the sound. And there we go. Can everyone see that okay? Lovely, thank you. Oh, there we go. So, my name's Leanne. I'm a trainee clinical psychologist, currently on placement with the PPN Northwest and currently working on a project with the Experts by Experience Steering Group. So yes, so today we want to really showcase some of the work that the group has been doing and also to really gather some feedback about how the group can help your services as well. So how can we adapt the work that we've been doing to suit your services and to work together a bit more. So just to start off with, I guess, is just a bit of feedback and context about expert by experience involvement. So this really goes down to the core of the NHS Constitution, where this states that the patient will be at the heart of everything that the NHS does. There's also a national requirement for the public to be involved in the design and delivery of healthcare services. And also an expectation that experts by experience are involved in all stages of psychologist training as well. There are a number of benefits to expert by experience involvement, but despite this, we know that there's quite a variation in terms of how much services involve expert by experience, and there's a great deal of variability in terms of the involvement across training programs as well in the psychological professions. So just to start off with, I will hand over to Claire on this pre-recorded clip to speak a bit more about establishing the group. Do you mind telling us a little bit about how you got the group going and how you kind of networked to facilitate that and what was required really to get it established?
Yes, so we were very keen in the Northwest to look at how we could develop meaningful involvement of experts by experience within the network, and it was something that we thought about very carefully for some time. And then the impetus came for us to make a plan with the development of the PPN England vision, which really put experts by experience and communities at the centre really of the work plan for the psychological professions in the regions. So we looked at where experts by experience were currently meaningfully involved, and that led us to the 3 doctorate in clinical psychology programmes in the Northwest at the University of Manchester, Liverpool and Lancaster, all of which had a public patient involvement group. And we asked for representatives from those groups, 2 people, in order that people could buddy up. And we formed a task and finish group for 6 months. And the aim of that task and finish group was to answer the question, what does meaningful involvement mean and what does it look like? So that led us to the development of these 4 aims that you can see on this slide now. And from these 4 aims, we've now started to develop a programme of work that involves the development of resources, reaching into other projects for expert by experience involvement, and working with us in terms of recruitment and delivery of other objectives within the psychological professions work plan.
Thank you very much. And just some feedback from the group as well about starting the EBE steering group as well.
I've come to the PPN Northwest from University of Manchester's clinical psychology department. Their experts by experience group is called the Community Liaison Group. And I was approached by the guy who was chairing that group, James Lee. Basically, James said to me, a group is starting, throughout the Northwest region. Would you be interested in being part of that sort of conversation? And I said, yes, I would. What struck me immediately, this was right in the throes of COVID and lockdown. And one of the things, actually, one of the really positive things, oddly enough, to come out of COVID and lockdown was we were suddenly getting used to the notion of Zoom and Teams. And so a group of people from quite a large geographic regions who all come together via the internet and have very useful and meaningful conversations without having to leave their living room. And I thought that was a hugely important impetus, which could perhaps not have existed had it not, oddly enough, been for COVID. So at one of the bleakest times in our, if you like, recent medical history, something was starting that was actually, making that voice of the patient, the service user, more and more important at a time when this was going up the political agenda anyway. And so to be part of that conversation was hugely important, and particularly being at something at the start of something is, hugely important. And I think it was that sense of wanting our voices to be heard, but how could we best do that? And what was Manchester doing, which other places like Liverpool or Lancaster may have been doing better? And that learning from other people about what's going on at your site, can we learn something from it? Suddenly I felt I was joining a bigger and a wider conversation. And I think that was the key thing for me.
Great. And so this section is just about the group's views on the development of their aims and really the value that they had in this. So I'll play this one.
I'd like to go back to almost the start, really, and that's thinking about all of us who are members of the EB steering group and how the aims were constructed, and really that was values led. So I'm just going to cough.
Okay.
So I think the values-led aspect of developing those aims really, this was developed in co-production. Those aims weren't handed to the group.
Yeah.
Those aims had to be thought about and discussed based on those values. And I think really promoting, improving, integrating and supporting were key for all of us in terms of wanting to develop this network, wanting to showcase the EBE voice and the benefits of EBE involvement in developing psychological professions and also broader. And we've had the opportunity to work cross-region, and I think that's one of the things as we go forward, that's one of the areas that we really need to focus on. And I know that that's really in our background. It's one of our thoughts going forward. I mean, partly, obviously, this was within the animation to take that message wider, but also to really grow that network of how we can work cross-regionally to develop in the future.
Great. So that was Alison just talking through the development of the group's aims. And one of the first aims is about promoting the expert by experience involvement across the profession. So really trying to promote the voice of the expert by experience. And one of the main ways that this has been achieved by the group over the last few months is the development of a new animation. So this was co-produced with the group. and it was really designed to try and encourage best practice and promote expert by experience involvement across health and care in the NHS. So I will share this animation on the next slide, and then we'll also talk through a discussion tool which has been produced with the group to work alongside the animation, to really kind of, rather than it being like a oh, that's nice, you know, the animation's more of a starting point for a conversation, and hopefully the discussion tool will help services to really think about how they go about developing their involvement. So I'll go ahead and play the animation.
Experts by experience are people who have used or cared for someone who uses our services. Their voices play a vital role in shaping delivery of care, teaching and research. They inform, enable and influence our work. Let's meet some of them.
Hi, I'm Alison. I've experienced lifelong poor mental and physical health, but in recent years my path has taken a new direction. When a clinical psychologist shared with me how experts by experience had shaped her training and practice, it was a light bulb moment. I saw how using my experience to help others could become part of my map to recovery. Now, I use my lived experience to support the Doctorate of Clinical Psychology at the University of Liverpool and shape trainee experiences. I'm a member of a steering group for the Psychological Professions Network too. I inform best practice as a critical friend to effect change and deliver a better future for everyone.
Hi, I'm Joe. I'm part of the Community Liaison Group at the University of Manchester and the Psychological Professions Network. Earlier in life, I struggled with anxiety and depression, and the support I received had mixed results. Due to a happy, lasting relationship, I'm now anchored in a safe harbour, and I can look back on my experience and use it. As an expert by experience, I've co-produced lectures and advised trainee clinical psychologists. I've gone from clinging to a raft in a stormy sea to being co-pilot on the ship's bridge. I feel empowered, listened to, and my self-confidence has grown.
Hi, I'm Hilary. I think when experts by experience work with course providers, it's like planting a shrub. If they are tended and fed information about aims and requirements, the expert by experience can contribute to the course growing stronger. Gradually, the roots of the expert, lecturers and students become entwined, and everyone blooms and thrives.
And I'm Claire, a psychological professional and a member of the Psychological Professions Network. Working in the NHS, I've found that people who have experience of using services have the most valuable insights into what works and how things can be improved. Experts by experience already bring so much, but they can offer so much more. As clinicians, teachers, commissioners and planners, we have an opportunity to learn from and share expertise with people who use services, to not just collaborate, but to co-produce. Bringing our voices together to improve the quality of services and deliver excellent healthcare.
Yeah, so that's the animation, and the group are really proud, I think, of all the work that went into that. And yeah, like I said, I think it's a really nice starting point to that conversation. So on the next slide, I will share, we talk through the development of the discussion tool to hopefully take this conversation to the next step and think about how can people start introducing experts by experience into their practice. So, get So this is the discussion tool that the group have developed to work alongside the animation. So the idea is that it encourages people to firstly watch the animation itself. And then we've got a section on discussion prompts to hopefully facilitate a bit more conversation around this. And then step 3 is to act and share. So hopefully to further encourage behaviour change and a bit of a call to action for services and individuals to think about how they can further embed EBE involvement in their practice. So we've got a number of questions there that we've posed for people to think about. And Alison and Hilary were quite heavily involved in the development of the content of these questions. So I wondered if it would be worth us maybe thinking about why it was important for us to be asking these questions and to be developing this discussion tool in addition to the animation. So Alison, would you like to speak first about this?
First of all, I want to say thank you, Leanne, because you've really helped us, and in co-production, to deliver this aspect of the animation. When the animation was completed, as I've said previously, we were all really proud of that piece of work that we've been involved in. But it became clear that this animation needed to still gain momentum. And the momentum that we've worked together to achieve is to find a way to encourage groups to use the animation as a tool for discussion. And so the toolkit itself and the development of the questions that we've done, again in co-production, as well as the actual materials and communications that go out alongside it, we've done together, really to really prompt that call to action. Our individual dynamic is really and our passion is for our EBE involvement. And really, I think that really comes through that discussion toolkit to take that out there, to get others talking. If you talk and if you act, you will achieve EBE involvement. And really, that co-production that we've worked with you with you, Leanne, I think has really achieved this in developing these materials. So thank you.
Oh, thank you very much, Alison. I've really enjoyed working on this with you all. And I feel like I've learned a lot myself about EBE involvement, so that's great. And Hilary, do you have anything to add to what Alison has already sort of covered?
Now, my feeling is that the animation is great, but we needed to make it more informative and make people understand how important experts are and take it to the next stage, so that you can put together, if you're at a university, you could put together an hour of talking about why it's important to involve EBEs and getting these things done. If you've got an EBE group just starting, why it's important for them. It's a set of questions that say why EBEs are so necessary and make them think about what they're going to be doing. And that's the most important thing, is A, to get your group going, and B, to understand why you need to be going and doing. And I think that the discussion aids in doing that, and then the act and share and the pledge is important, because that makes you achieve with your group. And that's the most important thing that we can get, that EBEs are involved everywhere and that they're useful and bring back important information to the group to share.
Yeah, absolutely. Thank you, Hilary, for that. And I think something I've just thought of as we were talking is similar to what you were saying earlier about some of the barriers to actually setting up groups, and sometimes a lot more thought needs to go into how, like, the practicalities and why it is you're setting up the group, how you're going to do it, how you're going to support people. And I think a lot of these prompts that we've developed will really help people to think about that a lot more. So that's the discussion tool, and I'll just show you briefly some versions that you might see on social media, on Twitter posts and in newsletters and things, which are just more condensed, but it's the same thing pretty much. And now we've got a section from the group where they really want to hear from you guys about how experts by experience and services can work together. And then I'll share a link to some feedback if possible.
I think it's really important that we've worked so hard on the animation. We really want it to work for every group that sees it, to be able to have those discussions together on how EBEs and EBE groups can help you in your work. So really the toolkit, which has been developed as a result of the animation, we really want to be a flexible and developing product for you. So we really need to know from you how you've used it, if it's been successful. We need that feedback, and how we can adapt it for future use. So we want it to be fit for purpose. We don't want it to be static. We want this to be adding to your service as a result of utilising the toolkit. So please get in touch and let us know how you've used it, how you could see it being used, and in the future, if for a particular group that you're working with, how we could adapt that to be suitable for you and your service.
Oh, fantastic. Thank you, Alison.
We want to know how we can be more actively involved as a group in helping you shape your work. One thing that immediately comes to mind for me is the work I'm doing at the University of Manchester in the Clinical Psychology Department. I think all academics throughout the country are overwhelmed by the amount of new trainees they're having to train, and how overwhelming their workload is. As EBEs, we can help, sort of with trainees, spread that workload and let us be more involved in lectures, in coming into group discussions with our lived experience, and help you to get the best out of your trainees.
Lovely, thank you very much. And our final point, Hilary, would you like to speak to that point?
Right, the third point is, by working together using co-production principles, we can optimise service, innovation and delivery. And this is so important because as things are now changing in the 21st century, and mental health particularly is a major feature, particularly after COVID, but even before then, it is not now the second service. It is becoming part of the mainstream, and everything we can do together to get it working properly is so important, and it can only work properly if EBE involvement in production and delivery of these services is included.
Yeah, so that's the call to action from our group. So we'd really love it if we could get some feedback from people about the discussion toolkit, and to think about how we can develop this further, what other things might be useful from the group in terms of informing our next phases of our projects. So I will pop the link to the survey in the chat if that's okay. And yeah, feel free to get in touch. We've got a website where you can access all the materials, and I can make sure those are shared as well. Thank you very much.
Thank you so much for that, Leanne. That was a really, really interesting project, and I really enjoyed the animation, and I particularly like the discussion toolkit. I'm thinking about, my role in a, as a clinical lead of a busy talking therapy service, it's really useful that, some of that, it kind of gives us prompts. Some of that work is done. It feels like it's really ready to use, which is really, really useful. And, kind of gives quite clear outlines, quite clear steps that you might take to kind of begin that process of involving experts by experience. So I thought that was really, really useful, and thank you to you and the steering group for producing that for us.
Thank you. I'll make sure to pass along the comments. I really
Yeah.
appreciate that. Thank you.
Yeah, and if services do make use of the toolkit, I guess you've put the links in on the slides that will be shared for how we might give some feedback to yourselves and the people who have developed the toolkit.
Yes, definitely. So I'll make sure those are shared, and I'll also put the link to the survey in the chat as well for today. Thank you.
Great. Thank you. Thank you very much, Leanne. So our next slot is onto the research slot, and our first speaker in the research slot today is Hazel Bennett. Hazel, I can see you there on our screen, and you are going to talk to us about predicting treatment outcomes in improving access to psychological therapy services. So Hazel, I'll hand over to you.
Thank you. That's right. Hopefully people can see the presentation that's just showing. Is that okay? Yeah. Okay, great. Thank you. So so I'm just going to talk a little bit about a study that we've done within GMMH, Greater Manchester Mental Health, just within the Psychological Therapy division. And we were just interested really in using some of the data that we gather to think about whether there are elements that would be predictive of recovery in a sample of the clients that use our service. So particularly interested in this really because we know that there is variation across not just services within our trust, but across kind of nationally across different CCGs. And there's been a number of different predictors identified within the research that might explain some of the variation. So some of those that have already been looked at, we kind of split into either treatment related or client related predictors. So we know some of the treatment related predictors, things like kind of the number of treatment sessions, so increased number of treatment sessions can be positively associated with recovery outcome, whereas things like the number of missed appointments and the waiting time can be negatively associated with outcome in the literature. Also been some research to suggest that higher step-up rate can be positively associated with outcome, and some starting to kind of get some information through on different problem descriptors that might have different rates of kind of recovery associated with them. And in terms of the client related factors, we know, I think from the literature, it's quite kind of clear really that employment status, higher social deprivation, higher levels of disability, higher baseline kind of symptomatology, so kind of higher levels of symptoms on the PHQ-9 and on the GAD-7 when people come into the service can all be negatively associated with outcome. If we're just looking at outcome based on recovery as defined within NHS Talking Therapy services. And also some information about whether a comorbid diagnosis of personality disorder can negatively impact on that recovery outcome as well. So we're interested kind of in some of these factors and thinking, well, some of these kind of predictors that we would be gathering routinely and whether this kind of holds true in our sample. But what we were also quite interested in, not only the client focused and treatment related factors, but to kind of add to the literature really. Anecdotally, I suppose we're kind of aware of the impact of motivation to change on recovery in our clinical work. So we know, I think, a lot of clinicians will speak to this, and those of us who work clinically as well, that when people come into a service, if they appear to be really quite motivated, engaged, that tends to, again, we kind of felt anecdotally, it tends to really lend itself to a positive outcome in therapy. And when we looked at the research, there didn't seem to be an awful lot within primary care NHS Talking Therapy services on this. Of course, there's quite a bit about motivational interviewing and motivation within substance misuse services. But when we're kind of looking at it within, say, kind of CBT or talking therapy, there might be certain elements that suggest motivation to change that are measured, such as adherence to homework tasks, this sort of thing that would suggest perhaps a non-adherence might be about motivation. But it was something that we thought would be helpful to look at a little bit more. So in terms of the methodology, there were 3 sites across Greater Manchester that took part in this survey, and that resulted in 1,135 clients that we were able to use the data for. So the variables that we specifically looked at, there were 3 treatment-related variables. So these were the waiting time that people had waited to commence therapy with us, the total number of IAPT referrals, so the number of referrals that had to an IAPT service previously, and including the current one that we were looking at, and the intensity of intervention. So that was just coded as either low intensity, so where they remained at step 2 for their intervention, or high intensity, where it was step 3 or 3+, that we had in our services. In terms of client-related variables, we looked at their employment status, the duration of the condition that they're presenting with, so the number of years that they identified having struggled with that problem for, the number of different presenting problems that they identified, assessment as wanting to work on. And also they've completed a clinician-rated measure of motivation to change. So we asked all of our clinicians, we did this as a kind of sample, a snapshot, if you like, of their caseload at that time, and asked them to fill in all of these variables for each client on their caseload. And specifically for motivation to change, we asked the question, how would you describe your client's motivation to change at their first contact with them? And we asked them to rate that as either low, motivation to change, medium, or high. So it's just a clinician-rated kind of measure, really, of what they felt the client's motivation to change was at that initial point in time, that initial assessment. And the outcome was looking at recovery status. Okay. So in terms of the sample that we ended up with, I guess this is just some descriptives, really, so you can get a sense of how representative it is perhaps of typical NHS Talking Therapy services. So generally, I suppose 68% had only had the 1 referral, so this was their initial first referral to services, to NHS Talking Therapy services. So 32% had previous referrals. As you can see, a kind of mean time to enter treatment was about 36 days. So quite a few started their intervention at low intensity, but the vast majority finished their intervention at high intensity. Average about 11 treatment contacts. Most had a planned discharge, and 52% achieved recovery at the end of their intervention with us and at discharge. So quite representative, I think, certainly of our services within GMMH. And then in terms of the client-related variables, nothing too surprising here, I don't think, from that's typical of kind of services, larger proportion female, kind of probably, yeah, quite might be surprising, 57% employed. I think on that one there was kind of 15% were seen as long-term ill or disabled, as it was captured. And then in terms of the motivation to change, so 47%, so the majority are kind of seen as moderate or rated as moderate in their motivation to change, but we had representation across the 3 categories of that. So there's 14% were rated as having low motivation to change at their first appointment, and 38% were rated as having a high motivation to change at their first appointment. And some comorbidity and chronicity there to be expected, I think. So when we kind of put all this into regression analysis, the final model classified 69% of the cases. They're correctly classified as either recovered or non-recovered, and explained 28.1% of recovery variance. So it's a statistically significant model. But what we found was actually of the treatment-related factors that we looked at, it was only the number of previous IAPT referrals that was a significant predictor. It was the only one that kind of came out as significantly predicting recovery. And as you can see, actually, just for 1 previous referral to the service, the likelihood of recovery decreased by about 30%. And you'll see in a moment, I'll show the graph of just how that recovery outcome kind of drops off with every subsequent referral to the service. In terms of the client-related problems or client-related factors, so the employment status was the most significant, or one of the most significant outcomes that we looked at here, and the only one of the standard variables that we looked at that was significantly predictive. So again, to kind of employ people, if they were coded as employed, were 70% more likely to recover than those who were unemployed. So, or that were long-term sick and disabled. But of particular interest for us was this motivation factor that we looked at here. So you can see people who were rated by their clinician as having high motivation to change were almost 10 times as likely to recover as those who were rated as low motivation. And people who were rated as having a moderate motivation to change at their first appointment were over 4 times more likely to recover. So this was kind of really interesting to us, and I suppose confirmed what we thought anecdotally from working in these services. So you can see there, just from the graphs, as I say, the number of previous out referrals, recovery drops off significantly for each referral to the service, and again with employment status. So long-term ill being the one that's kind of most associated with poor outcome. Unemployed also being was significant as a predictor as well. Okay. So again, just to kind of demonstrate some of the differences in the findings. So with motivation to change, both moderate and high motivation to change associated with a better outcome than low motivation to change. And you can see that there as well, where the highest motivation to change is significantly better outcome than either medium or definitely than low motivation to change. So I've whizzed through, but obviously we've got time for questions as well. But I guess just thinking about the implications of this then for our services. Obviously, this is just, you know, a snapshot, a sample from 3 services within Greater Manchester, so just over 1,000 clients. And it was collected retrospectively, particularly, I think, limitation there being that it was the clinicians that rated motivation to change. So we didn't have a kind of standardised measure of motivation to change that we were able to use at that initial assessment. It was very much just kind of what the clinician thought and how they rated what they felt the client's motivation to change was at that first appointment. But I think it lends stuff to thinking about how can we use this information. You know, motivation to change has a significant impact, it seems, on outcome. It's not, you know, motivational interviewing isn't something that we typically incorporate into either our assessment phase of working with somebody or our interventions. We don't use a standardised measure of kind of readiness to change or readiness to engage in therapy. But this is something that's made us think about, should we be paying more attention to the role of motivation, really, and a client's motivation to change in the work that we do with them. There's plenty of further research implications as well in terms of other variables that might be predictive of outcome that we weren't able to look at here. We didn't have enough information on diagnosis to include that in the study. And I know there's the research going on looking particularly at things like adherence, so the clinician's adherence to a treatment model, things like clinician seniority and things as well that might impact on outcome, together with different, kind of merging evidence on different problem descriptors and presenting problems that might be quite interesting as well to follow. But that's yeah, that's what we looked at. So happy to kind of engage in any conversation around that or any questions. Stop sharing. Oh, I think you're muted, Christina.
Yeah, the dreaded mute button. Just to say thank you very much, Hazel. I found that really, really interesting and such a rich exploration into the data. You know, I think, yeah, really, really interesting. And, you know, thank you very much for presenting that. I can see Dale has his hand up. Do you have a question, Dale, or a comment?
Yeah, well, firstly, just thanks for talking us through that, Hazel, so clearly. It's a complicated data set and it really made sense. It was just really a reflection point on when I did my cognitive therapy training in the late 90s, there weren't as many conceptualizations of disorders or models around. It was a real burgeoning period for that. And part of the process of training at the time really was about that almost kind of macro level formulation of, what's a person's understanding of the nature of their difficulties, what do they see as their kind of the maintenance factors, what's their implicit model around what's perpetuating that, do they have a sense of the perceived importance of making changes or trying to cope in a different way, and do they have a perceived sense of efficacy to implement the changes that might be required to cope differently. And I think that was kind of very much a key early part of socialization. And I just wonder whether there are training implications going forward. It's a much better charted land to common mental health disorders these days. Our training experiences now, or for people coming through now, there's lots of, kind of models of disorders, lots more evidence around things. But I just wonder whether there are training implications to kind of almost not forget that what I would say is a core basic of cognitive behavioral therapies, and a real strength of it, which is actually looking at that kind of meaning and understanding from the person's perspective. And those two key motivational things, perceived efficacy and perceived importance of change.
Thanks, Dale. That's a really interesting point and really important to think about that, particularly given some of the data that you've shared with us today, Hazel, about the importance of motivation and, kind of paying attention to our service users' level of motivation as they come into treatment. Yeah. Carter, you have your hand up. Did you have a question?
Hi, yes, I was trying to find the mic button. Just a clarification question, really. Did you say that you do now have a questionnaire to assess motivation for change before starting therapy, or something you're thinking of doing that haven't?
No, it's something, I think it's something to consider. There isn't a standardized measure that we use that we've incorporated into all our assessments. I think clinicians currently will use their own way to kind of assess somebody's motivation. Certainly a question that we ask people generally when we're thinking about goals, when we're thinking about readiness to change, we're asking people if they can think about any barriers that might get in the way of them making the changes they'd like to incorporate. We have thought a bit about some of the questions asked in motivational interviewing. So kind of how important is this change for you right now? How confident are you in your ability to make changes? But we've not introduced a kind of standardized measure. I think we've done a bit of kind of looking around to see if there's any evidence really of using a standardized measure to assess motivation change within our sort of services. And I think that's something that needs to be explored further, probably, to see if there's anything that does actually significantly become associated with outcome, or whether at the moment I think it's more about asking some informed questions and having those conversations with clients that's been the kind of outcome of this, really.
All right, thank you.
Welcome.
Are there any other questions or comments for Hazel before we hand over to Dale for the next part of the presentation?
There's some interesting comments in the chat. I'm just trying to read whilst listening and talk is quite a challenge, isn't it? But a few interesting comments about the impact, definitely, of therapist effect, staff turnover, staff kind of instability, which I think, and the lockdown as well, and pandemic. I think that's a really interesting topic for research at the moment. And I know Jamie Bellagio at Sheffield's looking at some of these factors. I think definitely about a kind of therapist effect, and they're doing a trial of it to try and seeing whether matching certain therapist styles or experience and qualifications with certain presenting problems might be predictive of outcome as well. So definitely, the therapist is a big contributor, aren't they, to the outcome. So I think that needs exploring a lot more. Yeah.
Great, thank you, Hazel. And I can see a comment here from Liz around PWP training explicitly considering motivation with everyone they work with, and wondering if we can get better at how we do that. So it seems like, in terms of kind of a training issue, it seems like it's already being looked at as part of the PWP training. So thanks for that, Liz. Okay, so we'll now hand over to Dale for the next part of our research slot, and Dale's going to talk to us about exploring access and engagement with improving access to psychological therapy services before, during, and after the COVID-19 lockdown. So
Lovely.
over to you, Dale.
As you can see, I'm not Irini Verbist, if anybody knows Irini, but unfortunately she couldn't make it today, so I'll save any complicated statistical questions for her. Do you want me to share, Christina, the presentation?
Yes, please,
Okay, right,
Dale, if you
apologies.
can.
That will just take me a moment to arrange that. Okay. Yeah, it's not giving me the option at the moment, but I'm sure it will turn up. Okay, has that come through?
Yeah,
Fabulous.
that's great, thank you.
Okay, so we're going to be kind of following on from a question in a way, as we will do in the next presentation as well, but looking at access and engagement within talking therapies before, during, and after the COVID-19 lockdown. So in terms of background, I'm just going to flash up a kind of typical client journey that will be familiar to most of us. Christina's sitting right in the middle of my screen, so we'll just have to move you. We're going to, it'd be useful really to bear in mind some of the terminology. So when we're talking about access in this context, we're talking about, I suppose, what typically an IAP will be called completing treatment. So people who have access here refers to people who have 2 appointments involving treatment. And engagement in this presentation refers to people who've completed a planned ending. So the discharge has been agreed or worked towards. So it is actually a completed treatment, if you like. And I suppose the third variable to bear in mind is entering treatment. So everybody has at least 1 appointment. So we're all familiar with the dropout points. It's always harder to make sense of the dropout between referral and the initial appointment or that initial entry. There's lots of historical data about that, looking at what makes a difference in terms of professional referral, in terms of reducing or increasing the likelihood of somebody entering treatment after they have been referred or self-referred. And we're planning to do our next bit of research on access and engagement is looking at that cohort of people who go missing. But today it's really looking at the difference between entering treatment and accessing, as in having 2 appointments, and the difference between accessing and coming to a planned ending, as in this terminology, engaging in treatment. So lockdown seems a long time ago sometimes when it's started, but it was March 2020. And prior to that, if we looked at our activity the year before, which may be similar to many of us in the room, 73% of people accessing our treatment in 2019 did so in person, 27% via telephone-based appointments, and 0% video-based appointments. And I have to say, almost the total of that 20% telephone-based appointments were initial telephone appointments on access to the service. There were some people who were continuing mainly step 2 intervention via telephone, but the vast majority of that 27% were just initial appointments. So during lockdown, this is what the medium of communication looked like. We were all getting to grips with MS Teams and other formats around video-based appointments. So we had 88% of our activity was telephone-based, and 11% video-based, and 1% in person. So what we wanted to do with this was to kind of get curious, really. You know, did it make a difference in terms of rate of access and engagement with the IAP treatment before, during, and after lockdown, and if there were any differences, which client characteristics predicted either decreased or increased the likelihood of accessing treatment or engaging in treatment. We looked at a large section of data, nearly 47,000 clients who had at least one treatment appointment, and then we chunked people into a kind of matched retrospective design. We looked at the time periods between March and September in 2019, March and September in 2020, and March and September in 2021. So it was kind of before, during, and after, with kind of round about 3,500 people in each group, so about 9,670, I think, overall. So what did we find out from that? So in terms of access rate, if you look at the lighter green column on the left, 60% of people who had entered treatment before lockdown accessed treatment, so went on to have 2 treatment appointments or more. During lockdown, it was the same 60%, and after lockdown, it was a 65% of people who accessed treatment. In terms of engagement, 49% of those who've accessed before lockdown went on to complete treatment, so seen as an engagement. They actually worked to a meaningful endpoint, however many sessions that were, and some of those were a lower number of sessions, but they worked towards a planned ending with the therapist they were working with. Now, it was 55% during lockdown and 55% after lockdown. So basically a 5% increase in access and engagement. When we looked at risk factors for access to talking therapies, and we controlled for some of the things that we thought may make a difference, so that we weren't of primary interest this time, so symptom severity, service area, so which service they accessed, and some treatment-related variables. We then looked at what independent variables kind of predict the dependent variable of access. And during lockdown, unemployment was a strong negative predictor. So people who were unemployed that's an odds ratio of 1.4, less likely in comparison to the baseline to access therapy. There's a positive predictor in terms of people who identified a Black ethnic background, were increased likelihood of access and treatment, and increased likelihood from people who were perinatal as well. After lockdown, the unemployment variable remained with again a 1.7 odds ratio. So people who were unemployed were less likely to access talking therapies. Moving on to engagement, so reaching a planned ending with the therapist. Before lockdown, age was a strong predictor, unemployment, perinatal, and having identified prescription medication. So all of those making it less likely that somebody would engage or work to an endpoint within therapy. And with age, it was the younger age people, that was the direction, and that was the direction throughout, where it was a negative predictor of engagement. During lockdown, we had similar variables coming through with age, unemployment, or employment status, but identifying as being unemployed, perinatal period, prescription medication, and a positive predictor of having a long-term condition. People with a long-term condition were more likely to access during a lockdown. And after lockdown, the 2 strong variables remained, which were age and unemployment status. So I suppose this is in the context of a 9% national increase in IAPT access during the period, high acceptability from clients and clinicians. A separate piece of research we did, which isn't being presented today. Some of you may have seen it at a previous PPN conference, but we did 2 acceptability surveys with clients and clinicians when we first did that profound move over from predominantly in-person delivery to predominantly remote delivery. And we got pretty universal and very reassuring feedback, both from clinicians, particularly the second time from clinicians, and from clients, that it was an acceptable means of delivery. And it was also contributed towards, or was associated at the time, with a reduction in waiting times as well, which is always helpful. So constant predictors throughout, you've got variables such as increased symptoms, decreased engagement around that. There's some issues came through from the surveys about lack of privacy, or the inability really to have space within the home environment to have the kind of conversation that you would, depth of conversation that you would envisage needing to have with people. Unemployment, there's a trend really towards kind of long-term illness as well, and a suggestion that that would be a constant negative predictor. Some of the positive predictors that came through in the period were kind of perinatal. There was an increased access rate, the flexibility around remote therapy. Anybody who's had young children know that it's incredibly difficult to cover the care needs around that and find time sometimes for your own care needs. The flexibility around that really enables some adaptation to that context. Medication prescription within lockdowns, 60% of the sample were, or reported, maybe higher rates than that, but 60% reported being on prescription medication, and higher baseline severity as well. Those were predictors which came through. Long-term conditions, it felt like that remote therapy option, and I think particularly after lockdown, it being optional, enabled increased accessibility for clients with mobility issues. And there was a positive improvement around people with a Black ethnic background, particularly in the lockdown period. All of the data is included in much more detail in this paper if you want to kind of have a look through that and access any of the specifics. Or there's as you can imagine, there's an awful lot of data that's been analysed to come up with these conclusions. So, any questions from anybody?
Liz.
Hi Dale, thanks for presenting that. It's such a fascinating area. I think what I'm really interested in, and it's more a comment really, is how much is telephone compared to video? And I really noticed a shift in practitioners' views of, prior to lockdown, kind of really not liking doing telephone work and would rather see a person face to face in a room. And then when we moved to lockdown, suddenly the preference being the telephone rather than the video. And I'm really interested in what it is from a practitioner perspective as to what suddenly makes them so much more okay with the phone than wanting that face-to-face interaction, even if it isn't a real life one, and whether that's just about technology not being as reliable as we would like it to be sometimes, or how much of that is about practitioners and how much of that might be about our patients as well, and them having the right setup to be able to do telephone. And I know it isn't your research per se, but I just wondered if there was any kind of attention given to that at all as part of it.
Not as part of this study. I think when we looked at the acceptability for clinicians, we didn't do that actually, quite interestingly. Maybe it would have been a good additional question to ask. I mean, what we didn't ask, whether you prefer to use telephone or video. I mean, I have to, shyly raise my hand and say I was very nihilistic about the move to telephone-based appointments, and felt underconfident in terms of the ability to deliver what we needed to deliver. And I suppose it's a core old behavioral principle, isn't it? You know, that continued exposure and I suppose immersement in it by necessity. And I feel far more confident as an individual doing that. And I think that I would like to think that that generalizes to all the staff groups that we sampled. And that certainly came through in the acceptability survey that we did. We have seen a gradual increase in video-based appointments, and I do think it helps. I do think it creates more of a link and an awareness. There's more information to go on. You know, you can pick up a lot non-verbally from the verbals on the telephone, and I think that you know, but it is additional information, and as long as the technology works, as you've said, and as long as it's something that's amenable to the client themselves, then I think that that's well, I suppose the pragmatic approach is it's an option available to people, you know, if they have that open to them. But we haven't done a comparison in terms of preference from a client, from a clinician perspective of telephone over video. We kind of get the client perspective, looking at the proportions of people who are, you know, opting for video versus opting for telephone.
It's just obviously from a PWP perspective, I find it really interesting because I think it's technically easy is probably not the right word, but from a guided self-help, to be able to do the screen sharing and to be really interactive with the self-help materials in the way that you can do in a room, it's definitely, there's advantages to video over telephone for that reason, for real practicalities of using self-help materials. But yeah, it'll be interesting to see how it continues to develop. Thank you.
Thank you. I think we have, I want to say Byron George, though I'm aware it might be George Byron.
It's Byron. Hi, Dale. Again, really interesting presentation. Just wondering if there's any sort of future research on those percentage changes in terms of face-to-face, knowing that there's a number of patients asking for return to a sort of an in-person appointment, but also just that picking up on what Liz was saying about that rapport in terms of going from a face-to-face to a telephone, and you obviously lose that body language and that sort of interaction, which I think is quite often a vital part of PWP training. So I don't know if there's any sort of future plans to assess from the lockdown 2020 whether there's a percentage return to, you know, in person, and what impact there is on, you know, that just general interaction with patients.
Yeah. Well, I think it would be worth doing, Byron. And I mean, I suppose we've kind of got the data in terms of the drift back to in person. And you know, to some extent, it's purely client led at the moment. We're in this, as I'm sure others are, a kind of position of trying to make sure we have enough clinic room availability and enough staff who've got, you know, time in their diaries in all of the services to cover the need and the preference for in-person appointments. But we've seen a drift back. I can't remember off the top of my head what it looks like now, but there's certainly more video-based appointments. There's probably less telephone-based appointments, and there's more in-person appointments. But I think it would be a really interesting piece of work to look at that kind of change in perspective from a clinician perspective, in terms of confidence and acceptability, and I suppose, you know, the sense of kind of credence as well of the medium, you know, kind of having if you've worked with complex people and facilitated meaningful change via telephone-based appointments for the first time in your career, it's quite an interesting experience to have, you know, especially if you've worked for a couple of decades or so kind of doing this. It's really quite interesting to test your own assumptions about things. So I think that we haven't got anything planned at the moment, but we do have a lot of the data available in terms of the raw uptake and usage.
Thank you.
Any other questions or comments? Dale, just checking the chat. I think we've had
Mark was asking, whether prior to they were encouraged to, and I don't think we did, Mark. I don't think we offered that as a modality. I think it was almost kind of almost like a last option if somebody was unable to attend, or but it was almost universally PWP step 2 interventions, but it's something which I think obviously that genie's out of the bottle. We know that people find it acceptable. We know we can facilitate change, and Laura will tell you how well we can do that in comparison to how well we did before.
Okay, thank you very much, Dale, for that really interesting, and
Thank you.
yeah, really interesting. Thank you. So Laura, you're up next, and Laura, you're going to talk to us about improving access to psychological therapies, analysis of effects associated with remote provision during COVID-19. So I'll hand over to you, Laura, for that.
Thank you. I'm pop my slides on the screen. Hopefully you can see this nicely. Excellent. So I am Dr. Laura Capobianco. I'm a research fellow at GMMH, and I'm the Assistant Research Director for the Anxiety, Depression, and Psychological Therapies Research Unit here at GMMH. So I'm going to be talking about, as Dale mentioned, kind of the analysis of the effects associated with remote delivery during COVID, and we've also compared this to how you did during face-to-face treatment. So, as we know, COVID had an immediate impact on service delivery, with services required to change their provision practically overnight. Services were faced with the challenge of maintaining access to current therapy, delivering access to current therapy, along with protecting the start of new courses of therapy due to be delivered. So in doing so, IAPT published guidance on delivery of remote therapy treatment, whereby services were now required to deliver therapy remotely. Now, there were challenges in doing so with remote therapy delivery, including difficulties in practicality, such as technology concerns for both patients and the therapist, concerns regarding confidentiality. Does the patient have a confidential space where they can feel that they can discuss their concerns with their therapist? And of course, concerns regarding the therapeutic relationship, if this could be established and maintained when therapy was delivered remotely. Now, despite these concerns, previous reviews have evaluated the effectiveness of remote therapies. For example, Berryhill et al. In 2019 evaluated video conferencing therapies for depression and found that video therapy was effective at reducing symptoms of depression when compared to face-to-face. However, less is known about how effective remote therapy is when it's delivered within IAPT services. Now, previous research, there was a case study done by Saunders et al. And a service evaluation by Nigan et al. Both of these studies have found that remote therapy has been associated with a decrease in symptoms of anxiety and depression. With services facing uncertainty regarding a return to face-to-face treatment and the need to improve service provision, we aim to have a look at what are the characteristics of those undergoing remote therapy in IAPT, both during COVID and pre-COVID. What are the effects on anxiety and depression symptoms associated with remote delivery of therapy, and how do these effects compare with those associated with face-to-face therapy delivered prior to COVID? So, we used a retrospective cohort and benchmark study of remote therapy, and we included 4 services within Greater Manchester. We used an intention to treat approach, so all patients with 1 attended appointment were included. The reason for doing this was because it provided a more pragmatic definition of a patient entering treatment. And then we also had a benchmark sample. So patients who entered treatment on or after March 23rd, 2020, and were discharged on or before November 26th, 2020, formed our COVID-19 sample. And we also had a benchmark sample, and this was those who received face-to-face therapy delivered between March 2019 and March 2020. So what exactly did we do? I won't spend too much time on the in-depth of the type of analysis we did, but we used the GAD-7 and the PHQ-9, which, as we know, are routinely delivered outcomes in IAPT to assess symptoms of anxiety and depression. We ran a mixed model with a fixed effects to assess change over time. This allows us to incorporate the number of days from entry when an outcome was recorded and a random intercept for slope for patient, as it's reasonable to accept that patients won't experience a uniform change in time. This model also allows us to take account of all the observations that a patient might have had recorded. So some patients had 1 to 44 visits, so this type of model allows us to use all of that data. So we compared change in outcome between remote therapy and face-to-face, and we did include pre-specified confounders. So we controlled for things like age, gender, therapy category, and therapist category. And as a sensitivity analysis, we reran all of our analysis with any variables, any demographic variables that were significant at baseline. And we also adjusted for PHQ-9 and GAD-7 severity at baseline. So, quick overview of our samples. There were a total of 5,515 patients in the remote therapy sample and 9,199 patients in the in-person therapy sample. Remote therapy, the average age was 33, whereas in-person was 35. The rest of the demographic characteristics were presented on the slide were more or less the same, roughly 64% female, 61% white, and roughly about 43 to 46 were in employment. The step breakdowns between the two cohorts also were more or less the same, maybe a variation of 1 or 2% between them, but about 25% of our samples were receiving a step 2 intervention, 66% were step 3, and a small proportion, about 8%, were receiving a step 3 plus intervention. So if we have a look at what were the primary presenting problems of our patients during these times, well, the majority of our patients, about 60% in remote therapy and 55% in-person, did not have a primary presenting problem listed. Where there was a primary presenting problem listed, the proportion of patients were pretty similar across the two groups, with about 5% presenting with anxiety disorder, 8% with depression, 1.7% with an adjustment disorder, 0.2% with personality, and 11% were classed as other. There was a slight difference between the two cohorts, in the proportion of patients seeking treatment for comorbid anxiety and depression, and that's this mixed category here is what I mean when I say mixed. It's just it was comorbid anxiety and depression. So there was about 15% who were seeking treatment for that in remote therapy and 18% in person. So we had, as I mentioned, 5,115 patients who attended at least one session during COVID, and 46% attended at least 2 sessions. In comparison to pre-COVID, so our face-to-face, we had 9,199 attend at least one session, and again, similar proportion, about 46% attended at least two sessions. The median number of therapy sessions attended during COVID was 2, and median number of therapy sessions pre-COVID was 3. It took 17 days from entry to end of treatment during COVID, but however, this is longer when therapy is delivered face-to-face pre-COVID with 25 days. And the number of days from referral to first session was 18 during COVID, slightly longer pre-COVID with 27 days on average from referral to first treatment session. So what were patients' reasons for ending treatment? So we had about 30% complete treatment in person, while 11% were classed as completed in remote therapy. Approximately 5.5% were discharged by mutual agreement in remote therapy, while less than 1% was in person. Now, in-person treatment, approximately 40% dropped out in comparison to remote therapy. Remote therapy did, however, have jumping a slide here. The one limitation we have here regarding reason for end of treatment is that in remote therapy, we have a large proportion of patients who did not have a reason for end of treatment. And I'll come back to that in a few slides to explain how this is problematic. So what did we find when we looked at how effective is remote therapy on reducing symptoms of anxiety and depression? So remote therapy significantly reduced symptoms of anxiety and depression over time. What this results in is an average reduction of 0.062 units on the GAD-7 a day and 0.067 units a day on the PHQ-9. So what exactly does this translate to? This means that on average per month, a patient reduced 1.86 units on the GAD-7. What this means is that it would take 3.33 months of treatment or 13 weeks of weekly treatment for a patient to cross the cutoff. Now, this is a bit of a crude assessment because this is assuming a more linear trend in time, and we know patients don't necessarily have that direct linear trend. But it does give us an idea of how much time it would take for a patient to cross the cutoff. Now this, when we look at the PHQ-9, we have a 2.01 average unit reduction on the PHQ-9 per month is how much they made, which this translates to approximately 3.8 months of treatment or 11 weeks of weekly treatment in order to cross the cutoff. But what happened in in-person therapy pre-COVID? Again, we see a significant reduction over time in symptoms of anxiety and depression, with remote therapy being associated with an average reduction in 0.039 units a day, and on the PHQ-9 is 0.042 units a day. So again, on average per month, patients are making about a 1.17 unit decline on the GAD-7, which that would translate to about 5.5 months of treatment or 22 weeks of weekly treatment in order to cross the cutoff on the GAD-7, and a 1.26 average unit reduction on the PHQ-9 per month, which translates to about 5 months of treatment or 20 weeks of weekly treatment needed in order to cross the cutoff. But how do these two compare? So is the reduction over time greater in remote therapy or face-to-face? So patients who received remote therapy during COVID actually had a greater reduction of anxiety and depression symptoms. These results were unchanged when we controlled for any significant baseline characteristics in terms of demographic variables and when we controlled for baseline severity. So what we see here, and apologies if I look to my left, I've got two screens on. So this red line is our in-person therapy. We see that the rate or this slope is a little bit slower than the blue line, which is our remote therapy line. So we see that this rate of change is a little bit faster. And that's for change on the GAD-7, and this is similar for the PHQ-9, where we see the rate of change, so how quickly patients change, is quicker on remote therapy than it is for GAD-7. But that being said, is that both treatments still do reduce symptoms over time. We also had a look at the MCID, or the minimal clinically important change. And this is the smallest change in an outcome variable that a patient would perceive as clinically meaningful. On the GAD-7, this is associated with a 4-point change, and the PHQ-9, this is a 5-point change. So of those that received treatment during COVID-19, 50% met the MCID on the GAD-7, and 55.3% met the MCID during face-to-face treatment. So in order to meet the MCID, this requires approximately 4 to 6 sessions of treatment. And this is similar for the PHQ-9, where during COVID, about 47.5% met the MCID on the PHQ-9 and 51.7% met the MCID on the PHQ-9 for face-to-face. And again, it requires about 4.6 sessions of treatment. So what does all of this mean for IAMPT? If we think of it in terms of service provision, the number of sessions offered and attended by patients who received remote therapy was similar to pre-COVID levels, suggesting that remote therapy did not appear to negatively impact on service provision or uptake and appeared to reduce the number of days from referral to first treatment. So it may provide faster access to treatment for patients. Now, it's difficult to assess the impact of remote therapy on dropout rates, as this is marred by some poor data reporting, as about 36% of patients didn't have a reason for end of treatment listed, so it made it difficult for us to assess the impact of remote therapy on treatment dropout. But both remote therapy and face-to-face treatment were associated with a reduction in symptoms, and those who received face-to-face did have a greater reduction in symptoms. However, The average treatment change was only associated with a 3-point change. So the rate of change was slow, with 16 and 15 weeks of treatment required to cross the cutoff on the GAD-7 and PHQ-9 in remote therapy, and 28 and 24 weeks in face-to-face treatment. However, these changes might be because the patient wasn't receiving an adequate dose of treatment, as the median number of sessions delivered was 3, and we're seeing that when we look at the MSID, a patient requires actually around 4 to 6 sessions of treatment. So in terms of the clinical implications, remote therapy was associated with improvement in outcomes similar to face-to-face pre-COVID. However, data was variable. It appears in order to meet target cutoffs for clinical improvement, more time would be required both for face-to-face and remote therapy. And remote therapy did appear to be associated with more rapid change in symptoms compared with face-to-face. But questions do remain concerning how effective the treatment element is and how much time is needed to realize an adequate dose. Really, we need more studies and kind of clinical trials to really test the effectiveness of these interventions. Any kind of questions?
So we have a question from Santo. I hope I'm pronouncing that properly. Yep. Santu. I apologize.
Yeah, I was really struck by the comment about change happening faster with remote, and I'm just wondering if you know what factors contributed to that outcome.
We don't. So it's kind of an average over time of what happens. I think it's a great question, and you're kind of thinking more about mechanisms and why that might be happening. And it's something that would need to be done for future research to really look into what is the cause of some of those changes.
Actually, I wasn't thinking in terms of mechanisms at all. I was thinking about motivation in the client, and whether the fact that there was, I mean, I don't know if it was a shorter period of time being offered remotely compared to in person, but sometimes when people are squeezed for time, they all of a sudden become much more highly motivated than if they were doing it indefinitely in person. So I'm just wondering along those lines.
Yeah, it's again kind of a great question, but it's something, motivation for change wasn't something that we had assessed, but something that should be kind of considered for future analyses.
And just a final question, was the length of time offered remotely the same as what they would get in person?
Dale, I'm not sure if you can comment on that one in terms of the length of treatment time offered there.
Yeah, I was just going to come in. Yeah, there were no changes to that really. I think paradoxically, I think what actually happened was there was an initial bit of tread and water went on right across services where people were adjusting and getting used to the different medium of delivery, but we don't have a model where we restrict the number of sessions somebody can have. It's more the case of how engaged somebody is, and kind of people need to manage the flow and throughput of the number of people they have, but there's not a magic number to work within, and there were no changes kind of remote versus in person.
Yeah, I think just one other thing to think about if you're wanting to do research that is not strictly about motivation, but also environment, the context that will have an impact. So if people are more comfortable in their homes, they'll, that will impact their ability to engage versus possibly experiencing shame if they go in person and someone seeing them, physically in that space. So shame is often not talked about, but is a huge factor in people's motivation. Yeah, I'll leave it at that. So yeah, that would be interesting to measure or research as well.
Absolutely, all great points.
Thank you, Santi. They were some really interesting thoughts there, really interesting things to think about. I'm just very conscious of the time, and I know how important comfort breaks are when we've been kind of sat in front of a screen for a while. So unless there are any other absolutely burning questions for Laura, I'm wondering if now would be a good time to to stop for our comfort break, and come back at 11:15.
Yeah, I think that's a great idea, Christina. We've got a really busy programme for the again after a great start to the day, some outstanding presentations, and very much looking forward to the rest of the morning with you all. So thank you very much, Laura and the rest of the team, and we'll see you at 11:15.